Thanks so much for having me and thrilled to be here. Thanks everybody. What I want to do today is share some of the work that we've been doing at the Healthcare Affordability Lab, which is, at its core, trying to produce work that's immediately relevant to policymakers. And then we want to take the next step of working with people like you to use the research we're doing to try to do some good and to try to move policies forward that I think at root can fundamentally raise the productivity of the US healthcare system and I think basically try to make the healthcare we're seeing out there more affordable for the American public. And what I want to do is start by sharing some of the research we've done on provider consolidation, how that's affecting prices and the wider economy. And then I want to turn to some of the tools that we've been making that I hope are going to be able to help you in some of the work you're doing across the country. So I want to start by just anchoring the conversation in three numbers. Right? The first is $27,000, which I'm sure will resonate with a lot of the folks on this call. That's the average premiums for employer-sponsored health insurance for a family of four. The second is median household income for a family of four, which is 120,000. So we're in a world where basically 25% of the income for the average family is going to healthcare. Now, the third number is the median mortgage in this country, which is $24,000, $25,000 a year. So families are spending more on health insurance each year than they're spending on their mortgage. So what I want to do is now sort of dive into why we're seeing that. So I'm going to share my screen. Jeremy, give me a thumbs up if you can see this. Fantastic.
Yep, we got you.
The 8 years on Zoom, whatever, we've gotten it sorted. So, this is the diagram I often put up for my students. I put it up when I give lectures, right? $27,000 for health insurance, you can get a pretty nice car for 23,000. And so we're in a position where the average family is, in a sense, buying a new Toyota Corolla's worth of health insurance every year. And I think what's incredibly important for us to talk about sort of internally, but more importantly with the public, is when we decompose the growth in insurance premiums into the share represented by the growth in healthcare spending, what we're seeing is that about 90% of premium growth is being driven by growth in healthcare spending. And so to get premiums under control, we've got to get healthcare spending under control. Now, I focus on hospital care for the same reason that folks rob banks, right? It's where the money is. The plurality of the dollars we spend each year on health spending for the privately insured are getting spent in hospitals. And what we've seen, and I think this is really one of the most important graphs in healthcare policy, is that prices in the hospital sector have, by and large, gone up faster than prices in any other sector of the economy. Right? They've gone up markedly faster than inflation. They've gone up faster than physician services and prescription drugs. And it's this combination, right? A large chunk of the spend that's growing massively faster than the rest of the economy that's pushing up health insurance premiums for the privately insured. And so the question is, why are we seeing this? Why are our hospital prices going up so much faster than prices in other parts of the healthcare sector? It is true that labor is becoming more expensive, but labor in physician offices is also becoming more expensive. One of the primary drivers is, in my view, the consolidation that we've seen across the hospital sector. So over the last 25 years, we've seen roughly 1,200 mergers amongst the nation's 5,000 hospitals. And if you just look at the raw counts, it almost looks like there was a slowdown in 2016, but what's actually happened is that most of the singleton hospitals that were available were getting gobbled up in the early part of the 2000s. And so what we're seeing is a smaller number of bigger transactions over time. There has been a bit of a slowdown post the pandemic. We're actually seeing in the beginning of this year another upturn in the number of mergers that are happening nationwide. The other thing that's really important to point out is there's a tranche of mergers, about 20% of them, that are actually running afoul of the FTC and the DOJ's merger guidelines. So the DOJ and the FTC come out each year with the horizontal merger, or every 10 or so years, with the horizontal merger guidelines. The period that were the guidelines that were enforced during this period said, look, a hospital merger that raises concentration, measured by a Herfindahl index, by more than 200 points, and leads to a market that's got an HHI 2,500 points or greater, we're going to say that that's likely to raise prices by lessening competition. A quarter, 20% of mergers are doing that. And during that period, the FTC took enforcement actions against 13 deals. So there are a lot of problematic deals happening across the country that are meaningfully raising prices that are going through in spite of pretty robust efforts to try to preserve competition in these markets. Now, what does this mean? I think first, not all mergers are problematic. So on the left, what we're doing is looking at all of the mergers that happened between 2010 and 2015 that didn't lead to a meaningful change in market concentration. And you basically see no price increases. Right? Conversely, on the right, if we look at the 238 that raised prices by HHIs more than 200 points and led to a net HHI of 2,500 or greater, these are raising prices 2 years out by nearly 8%. If you go out to the 3-year horizon, you're up at about 10% price increases. And so the question is, how do we identify transactions like the ones in the right panel? And then what do we do once we've identified them? And that's, in a sense, what we're going to focus on prospectively. Now, we can also look across the country. And we can say, look, hospitals that are monopolies, of which about 20% are, they're going to have prices in the cross-section that are about 13% higher than hospitals that face competition from 3 or more competitors. Now here's why this matters. I think we have a pretty good sense across the economy of what happens when firms come together, prices go up, right? It raises prices for consumers. Things are different in healthcare because most of the healthcare that we consume is funded by insurers. And in this case, the bulk of us get our health insurance from the employer. And so the ubiquity of employer-sponsored health insurance creates this mechanical link between what's happening in healthcare markets on the one hand and what's happening in labor markets on the other. So for an economist, when benefits become more expensive, right, that's not something that's paid for by the employers. It comes out of workers' compensation. And the theory is pretty clear, right? If the cost of a benefit goes up by $10, in theory, you're going to see a reduction in wages of $10, but it rests on one very, very critical assumption. And that's that workers value the benefits that they're getting. And the challenge is in the healthcare sector, where a lot of the spending growth has been driven by price increases, the same things becoming more expensive over time, we weaken that assumption. And when you weaken that, what the theory suggests is that instead of the added cost of benefits coming out of workers' pay, it's going to come out of their employment. And so we've done a whole bunch of work testing whether or not this happens. So we've brought together claims data from the Healthcare Cost Institute. So that's data from Aetna, Humana, and United back in the day. Insurance premiums from the Department of Labor's sort of mass insurance database. And then we work with the IRS and the Treasury via a program they have set up for researchers that allows us to have access to the universe of tax returns from the IRS. And so what we can do is trace through how increases in the price of healthcare feed all the way through into employment and wages, inequality, mortality, and tax revenue. Now, the sort of challenge for an economist is it might be that as companies get richer, they buy more generous insurance, and that raises the price of healthcare. We want the sort of causal chain, in this case, going from left to right. And so what we've done is trace through how hospital mergers and the price increases they create filter through the rest of the economy. And what we do is we look at all of the employers across the nation, and we think about which hospitals near them merged. We think about where patients get care, and for every employer, we think then basically about how exposed each employer was to the mergers that happened in the 2000s. So take Yale. A lot of our employees get healthcare in New Haven. The merger of Yale and St. Raphael's Hospital was actually one of the most problematic mergers we've seen in the country over the last 2 decades. It raised prices by probably north of 20%. Yale was very exposed to that merger. And so we think about what impact that had on Yale's employment relative to, say, another university. So we control for which industries the companies are in that happened to be nearby a merger that happened not to lead to massive price increases. So what did we see? The first, and I think, again, this is really important to just say out loud, prices lead to a dollar for dollar increase in healthcare spending, and in turn, a dollar for dollar increase in insurance premiums. So when hospitals merge and prices go up, premiums follow. The second is that those translated into a reduction in payroll in firms outside the healthcare sector. And that those reductions all happened on what we as economists would say is the extensive margin, job losses. So when health spending went up from hospital mergers, companies outside the healthcare sector let workers go. And we actually see, because you can't let a quarter of a worker go very, very easily, bigger reductions in payroll than we saw increases in healthcare spending. And so there's sort of a net loss of employment in the economy. And because when people lose their jobs, they're not paying tax revenue collected by the federal government went down. This is the part that is incredibly subtle, but is remarkably pernicious. So the college wage premium in the US is about 2 to 1. So your earnings are roughly double with a college degree. That's the biggest college wage premium in any wealthy country, sort of across the OECD. And the challenge is, we know that wages vary a whole lot within companies. Right? The CEO is making a tremendous amount more than the person in the mailroom. However, insurance premiums actually don't vary a whole lot across people within companies. And so the insurance premiums for the CEO are, at best double what the premiums are for the person in the mailroom. And so for a company that's facing higher healthcare costs, they can let go of $100,000 worker in this case, and they're going to save $9,000 in insurance premiums. So they're going to save a total of $109,000. Or they can let go of two $50,000 workers, and they're going to see the premiums on each of those go away. So they could save $118,000. So in theory, because premiums don't really vary that much, the incidence of rising healthcare spending should fall disproportionately on lower wage workers. It turns out that's exactly what we see. So what this graph is showing is who the workers are, who we see lose their jobs when healthcare prices go up. We actually don't see much at the very, very bottom of the income distribution. That's because those folks don't have employer-sponsored health insurance. But all of the increases in job losses are happening among workers who are earning broadly between $20,000 and $100,000 a year. Right? And that's why, if you look at some of the other work done by Amy Finkelstein and colleagues, basically rising healthcare spending in the presence of employer-sponsored health insurance is one of the leading, if not the leading driver of income inequality across the US. Right? So that's why we should be caring about this. We should be caring about it because there's a literature that I frankly wasn't aware of, but should have been, which is that job losses are tremendously destabilizing to a person's health. And if you go back through the literature, beginning in the 1970s and moving all the way forward to today, what you see is that on the order of 1 in 300 to 1 in 500 of the people who lose their jobs die within a year. There's a tremendous 50 to 70% spike in short-run mortality after a person loses their job. Chiefly concentrated among men. We can look at the causal driver, and it's chiefly hospitalizations for alcohol-related conditions, traffic accidents, overdoses, and self-harm. And one of the things that we did in our research was we said, are we seeing something similar? We're seeing pretty substantial job losses outside the healthcare sector in the wake of hospital mergers. What are we seeing in terms of survival? We see that a 1% increase in healthcare prices caused by hospital mergers is going to lead to one death for every 200 job losses. The reason our number is actually higher than we're seeing in the rest of the literature is because we are right at the heart of the opioid epidemic. We're not seeing any changes for folks over 65, right? Unsurprising because they're not losing their jobs when healthcare spending goes up. We're not seeing any deaths change acontextually of alcohol abuse and suicides and overdoses. We're not seeing any change in cancer deaths. So taking a step back, hospitals are the biggest chunk of healthcare spending. Their prices have gone up more than prices in any other sector of the economy. It's been fueled in large part by consolidation. And when we track through what happens after these prices go up, we see job losses concentrated among lower income workers outside of the healthcare sector. That lowers tax revenue, it increases inequality, and 1 in 300 of the folks who lose their job, consistent with this wider literature on healthcare, employment, and mortality, a decent chunk of the people are going to lose their lives. So that really sort of sets the stage for what we're trying to do here, which is to say, I think we've got a problem in provider markets. We've got a pricing problem. Can we give policymakers more tools to make a difference? And so this is the first in a series of tools that we're going to put out that try to, I think, equip you with an ability to visualize what's happening in these markets and assess which mergers are problematic and which ones aren't. So what we're going to do is build a database of hospitals nationwide, which is actually surprisingly challenging. There actually isn't a great database of all of the sites and systems. And so we've gone back and sort of painstakingly reconstructed what hospitals are across the country. We're going to do this for everybody except the VA, TRICARE, and long-term care facilities. We're going to make a dot. We've got Mass General here as an example. You can see the number of beds that are in the facility. The next thing we're going to do is for all of the hospitals nationwide, we're going to calculate a market for them that's based on a 30-minute drive time around their facility. This isn't the definition you'd use strictly in an antitrust case. That's going to be much more bespoke merger for merger. But this is going to get a pretty decent approximation. And then what we're going to do is we're going to say for every hospital, we're going to look out in that market, in this case, the red shaded region. We're going to say how many competitors are there in there? We're going to flag those, and then we're going to create a measure of concentration, a Herfindahl-Hirschman index, which is going to be the sum of the shares, some of the squares of the market shares of all the competitors in the market. And the HHI ranges from 0, which is a perfectly competitive market of which there are none, to 10,000. 10,000 is going to be a perfectly pure monopoly. And so what you see here is, the degree of concentration at Mass General is what, 2,200 points. Strictly speaking, across industries, this is decently concentrated. In the hospital sector, this is actually, as we'll show you, pretty good. And we're going to do this exercise for every hospital nationwide so that you can go click on a specific hospital and see the degree of concentration it's facing. So we'll generate hospital concentration measures for 4,500 hospitals. We're going to track changes in HHI from 2000 onwards. And you'll have a tool like this that you can access at our website, the healthcareaffordabilitylab.org. We'll plot the number of mergers. You can see that over here, and we'll drill into this in a second. You can see the transition from independent hospitals, as those have become scarcer, into large systems. Then what we're going to do is we're going to build a database of hospital mergers. So we're going to painstakingly go through all of the big merger databases that exist. And we're going to create a roster that we're updating in real time about all of the transactions that are happening. And we're going to flag ones historically that were red zone deals. These are deals that the DOJ FTC guidelines would have said are potentially problematic. We'll also do that for deals that are getting proposed. And we'll talk a little bit about what this looks like going forward. So in a sense, there are two tools that are out there. One is going to allow you to characterize existing markets. Right? What did they look like today? How did they get there? And then one that's an ability to see the potential impact of a merger going forward. So I'm going to give you a bit of a preview on what each of those look like. So the first thing we can do, and you'll be able to do using this tool, is say, how much have we seen concentration shift across hospital markets state by state? So a couple things to take away here. The first is there actually isn't a state that's doing fantastically well. So the average market across every state is well north of what the DOJ or FTC would consider unconcentrated, right? These are all markets with HHIs that are sort of north of 1800. So the second is we're seeing pretty sizable increases in concentration across many of the states nationwide. So, Vermont was already highly concentrated and stayed highly concentrated. Maine was pretty concentrated and became even more concentrated, right? New Jersey, which relatively speaking was less concentrated than other states, itself saw pretty significant increases in concentration over the last 25 years. And so what I want to do is dig into two states in particular that have seen pretty sizable M&A activity, and that's going to be New Jersey and Connecticut. So this is a visualization that's going to be part of a tool that we put out prospectively that's going to allow you to benchmark insurance premiums in the small, large, and exchange markets nationwide, CPI, and then healthcare spending. So Connecticut, where I live, is amongst the highest premiums in the nation. Right? We've seen premiums grow pretty quickly. They've grown markedly more quickly than the consumer price index. Again, that's chiefly because of the growth in healthcare spending. And we can look at what the hospital markets using this tool look like in 2000. And there were pretty concentrated markets, but if you zoom in, say, in New Haven, we had two hospitals from different systems competing against each other. Right? Most hospitals were sort of in the high concentration areas. They weren't monopolies except for the hospital in the northwest of the state. We had 20 transactions, right, across the state's 32 hospitals. 7 of those were at red zone transactions, all of them allowed to go through. Basically, every hospital in the state, but for the monopoly, saw their concentration rise by over 100 points. Right? So in a sense, every hospital in the state became more concentrated or already was a monopoly over the last 25 years. And the changes in HHIs that happened in Connecticut were in excess of what the FTC and DOJ's guidelines would suggest are problematic. Where did we get to? We got to a world where every hospital in the state is largely operating in a concentrated market. Right? The addition of 2 additional monopolies. If you zoom into Yale New Haven, right, the 2 biggest hospitals in our region came together. You now, in a sense, have a de facto monopoly in New Haven for hospital care. Hartford Healthcare, I think, is a really good example. In 2000, this is something you'd be able to do with the tool, is say, look, it was a 3-hospital system back in 2000. It had 3 providers. One had an HHI of 1,400. The other 2 had HHIs of about 3,000. We zoom forward 25 years, it's now a 10-hospital system. Most of the hospitals have a concentration measure of over 2,500 points, a handful that are going to be over 5,000. The same thing has happened. We've now basically turned into a state that's dominated by 2 health systems. Yale had 3 hospitals in 2000. They had 1,200, 1,300 beds. The average hospital in the Yale New Haven system had an HHI of 2,600 points. 25 years later, the average hospital is going to have an HHI of about 6,000 points. 10 hospitals, 2,900 beds. If you look at Yale, New Haven, or you look at New Haven, you can see 2 very, very concentrated hospitals in that area. New Jersey, another state with amongst the highest premiums nationwide and very, very high premium growth over the last 25 years. There is some anomalous reduction in premiums in 22 to 23. That's just, the data are a little noisy and need to sort of put confidence intervals on everything. Here's what New Jersey looked like in 2000. Right? So the hospital market up by Manhattan is actually pretty healthy, pretty competitive. There aren't too many monopolies. What we see in New Jersey is a state with 88 hospitals, so 29 transactions, 11 red zone mergers, and 20 hospitals that were involved or indirectly exposed to those red zone mergers. So a tremendous amount of M&A activity, which at the end has meant that 90% of hospitals in the state experienced a meaningful increase in concentration. Today, right, you look at the hospital markets, and there are a whole lot fewer of those blue hospitals, right? Ones that are in particularly concentrated markets, and markedly more hospitals that are in that sort of pinkish area, which are going to be hospitals that have an HHI of somewhere between 2,000 and 5,000. So that's, in a sense, our effort to give you the ability to say, what do our markets look like today, and how did they get there? The tool that I'm most excited about is the tool that lets you evaluate proposed transactions. What I want to do is look at two mergers that are out there right now and show you what the tool says about those. The first is going to be the RWJ-Barnabas Health proposed acquisition of Englewood Health, which is a singleton 283-bed hospital. And the second is going to be this West Virginia health system acquisition of Pennsylvania-based Independence Health System's 5 hospitals. So these are both transactions that have not closed yet, but are out there. So what I'm going to do is I'm actually going to close this down, and I'm going to share our tool itself, and I'm going to walk you through it. So let's go, and what we've got here is going to be our tool. So we'll zoom out. Let's look at New Jersey. Okay, so we can go to New Jersey. We can look at market concentration. We'll look at it this year. And this is the picture that I was showing you. We can pull up, let's go to RWJ-Barnabas. It'll auto-populate the different hospitals. And you can see this is a 14 hospital system. You can see where the locations are, the degree of concentration at these facilities. And if you go to Forecast Lab, what it'll allow you to do is simulate the effect of a merger. So we'll put in the company that's doing the acquiring, RWJ-Barnabas. We will put in this case, Englewood. We're going to go execute action. And what it's going to do is it's going to pop up, actually, that is not the right one. Let me change this slightly. So we're going to put in RWJ-Barnabas. I'm going to put in Englewood Health. Make sure this does it. There we go. And what you're going to see is we're going to give you the change in HHIs for every hospital that's going to be affected by this transaction. So the chief one's going to be Englewood Health, that previously was freestanding, that's now going to be owned by RWJ-Barnabas. It's going to experience a change in HHI of 63 points to a net HHI of 1,300. This isn't a particularly problematic transaction, at least from the perspective of traditional horizontal merger guidelines. It's not really going to affect the HHI of too many of the surrounding hospitals. There are some concentrated markets, but they're not becoming more concentrated because of this transaction. Conversely, what we can do is we can go, say, look at West Virginia. Unsurprising, and let's actually do it using the Market Explorer. Right. Unsurprisingly, like West Virginia is going to be a more concentrated hospital market than you're going to see in New Jersey. It's more rural. There are going to be less hospitals per given square foot. We can pull up one of the merging parties. So that's going to be Independence. And this is going to be in Pennsylvania. And we look at some of the hospitals here. So let's take a look at, we'll do, I don't know, let's do the let's do this one, the Accellafrix. This is part of the system. So it's going to actually have one hospital that's right over the border that does overlap with West Virginia University's health system. So if we sort of put our mouse over these, we can see it. So let's go to the forecast lab and see what's going to happen. So what we're going to do is go back to our merger tool and we're going to say, look, what happens if we go for West Virginia University Health System? It's got 21 hospitals. What happens if that merges with, in this case, Independence? And it's 5 hospitals. We can execute this action and okay, well, these are starting to get to much more concentrated hospital markets, right? The Ella Frick Hospital is going to now become part of West Virginia Health. It's going to see a change in HHI of 7,200 points. It's going to see a net HHI of about 3,500. We're also going to see an increase in the degree of concentration at West Virginia University's Medicine Uniontown Hospital, right? That was previously pretty concentrated. It was about 2,900. It's going to see an increase in HHI of about 400 to 500 points. So 2 transactions, one that looks, at least at first blush, largely benign. A second one that, based if passed as prologue, and if we buy into the DOJ and FTC's guidelines, is going to create meaningful increases in concentration and is likely going to lead to price increases. Right. Our goal here then is to say, can we flag transactions in advance so we know which ones to potentially scrutinize further? Right? Which ones to think about from an antitrust perspective, which ones to think about from a regulatory perspective. It isn't saying necessarily that this merger is bad. It's saying that it is likely going to change concentration. I'm just going to finish off and then we can open it up to Q&A. So we're going to have a couple more tools coming down the road. We're going to have a tool that's going to identify hospital openings and hospital closures, thinking about which regions each of those have occurred in. We're going to have a tool that's visualizing the growth we're seeing in insurance premiums and healthcare spending. We're going to have a tool visualizing hospital prices, and I suspect we're going to have a tool looking at physician markets. The reason we're doing this is I think if you're serious about affordability, we have to begin to address the growth we're seeing in hospital prices. There's just no way to make premiums more affordable without talking about the pricing of hospital services. I think that a large portion of the growth we're seeing in hospital prices has been from the consolidation we've seen in this market over the last 25 years. And I think, frankly, we have a choice. We can think about policies that encourage competition, and we should be thinking about those. I think those look like trying to get patients to be more comfortable going longer distances for care. I think we need to be thinking about policies that stop further harm. So that's basically more antitrust enforcement if there are deals that are problematic. And then I think we need to be really frankly having and engaging in policy about what you do in these 20% of markets where there isn't competition, right? Where there's just no scope for competitive forces to set prices, right? And in those markets, because I think we aren't going to unwind those mergers, we need to be thinking about how you regulate prices. So with that, I'm going to stop sharing. I think, Jeremy, we can turn off the recording, and then what we